Good morning, everyone. I am delighted to introduce to you Dr. Alexander or Sandy Simpson, who's a professor of psychiatry at the University of Toronto. He's research chair in forensic psychiatry and a senior scientist at the Center for Addiction and Mental Health, CAMH in Canada. Dr. Simpson has served in directorial and advisory roles on multiple national and international forensic organizations. He's a member of the editorial board of 7 journals based in Canada, UK, Italy, and for several international audiences. He's a member of the Council of Reviewers of the Canadian Institute of Health Research. He has over 140 peer-reviewed publications, 1 book, many chapters, monographs, and is an occasional columnist for the Globe and Mail. His academic interest focuses on the issue of violence and psychotic illness, including understanding the illness and social causes of violence, pathways into the criminal justice system, and therapeutic intervention and recovery. I met Sandy nearly 15 years ago. I was a young, recently graduated forensic psychiatrist, and we met at Apple in a meeting for the Committee for Cross-Cultural Affairs. And soon thereafter, we were involved in a panel discussion. And since then, I have been moved and always listen carefully when Sandy speaks. So with that, I will welcome Dr. Alexander Simpson.
Thank you, Chinmoy. Thank you to the department and for the invitation to be here. It's a pleasure to be with you to talk about, I guess, something of a combination of a professional and a life journey in relation to addressing issues of what is culturally competent care and the various terms and ways in which that's looked at. Although I will give reference to evidence, one's always aware of evidence being used to support the argument rather than arguments based on evidence. And this is an area where, to a considerable degree, we have to make steps and design and deliver services before the evidence comes, and to be responsible for trying to close that evidential gap. So a lot of it will be about what seems the right thing to be guided by people of wisdom to try and deliver services that make sense culturally, and the reasons as to why that's so important in forensic. I hope there's lessons for that in non-forensic services, because we, and certainly with the people with psychotic illness, who are the main people I've served across my life, the issues are not dissimilar in many general mental health settings as in forensic. So thank you for the chance to speak.
Sandy,
voice
is there a
level
camera on your laptop?
Turn that on.
Yeah,
and
and you know, and then the people who are online are, yeah.
And please let me know if my voice isn't clear on the people online. I have a bad habit of dropping the volume of my sentences as I go on, and remind me if there are any issues with that. So firstly, a land acknowledgement. At CAMH in Toronto, so we're a large mental health clinical service and research centre in the middle of Toronto. We're situated on land that have been occupied by First Nations in Ontario for many millennia. The St. Lawrence of the Iroquois and the Huron-Wendat Nation, the Seneca of the Haudenosaunee, are all traditional dwellers on that place. It is subject to land that has come under Crown and their general control via a thing called the Purchase Treaty number 13 in 1805 from the Mississaugas of the Credit. We're now an incredibly diverse city with people from many nations, including First Nations, Inuit, and Métis people. And we'll touch on the issues of reconciliation that it's mentioned at the end of that. I gather University of Minnesota is founded on lands that were Dakota lands originally, and acknowledge that we're on those spaces. No disclosures. I receive and continue to receive funding, but from non-industry sources. Acknowledgements are a tricky thing in this subject because there are too many to mention. Were I speaking in New Zealand, I wouldn't have started as I had. I would have started with acknowledging the people of this place, the land we mentioned, but the people who established this institution, the people who lead it now, and the work of generations before us that allow us to create the space that we're in now. I would then introduce myself in terms of my mountain, my river or my lake, my tribal origins, my family origins, and lastly, introduce myself. Some of my mountains and lakes and rivers will become clear as we go on. But the importance of that, and I'll talk further about the importance of what Maori people have taught me, the Indigenous people of New Zealand, is that it's important to acknowledge at all times who we come from, and where our place is in time, place, and history, and who we're connected to, because that actually defines much more than who we are as people. And there are many people of great wisdom who trained me in that or taught me in that, overtly and covertly over the 20 years of practice that I did in New Zealand. Much of the work that I'll talk about at CAMH is thanks to the person who succeeded me as Chief of Forensic, Dr. Trina Wilkie, and Samita Chatterjee, who's led the EDI project at CAMH in Forensic. And there are many, many people, 50 people in our division who've been involved in and continue to be involved in that work. And I'm speaking for them and their work, of which I'm a part, but not the principal leader these days. Okay, so what do I talk about? The origins of cultural responsivity and mental health, where that has come from, particularly my own and my own background, and I hope that will make sense in terms of narrative. The linkage of cultural responsivity to recovery principles and the way in which they represent a synergy that overlap, but depending on where you are distinct to some degree. The specificity and centrality of those issues within forensic practice, and some then about our approach in forensic. And this is as a reference there at the bottom, and the slides will be available after the presentation that we published last year in the Journal of the American Academy of Psychiatry and Law that describes the initiative at CAMH. So that's from last year. You'll see some more recent work from that and later on. So first of all, your orientation. There are a whole pile of truths that are hiding in plain sight, that as we think about our technical skills or we'll look at our levels of highly skilled research and investigation on mental health, we're at risk always of kind of missing. The link of crime to poverty, to marginalization, to structural alienation of various terms, the way in which those things combine, causing ill health, and the recent review and meta-analysis that has gone so far to say as poverty causes serious mental illness. Something that probably was an argument some years ago, but there's a good case for causation being in that sentence now. The overrepresentation of people of color in general in the services that we provide, and in former colonies of the British Empire, usually vast overrepresentation of people of Indigenous origin. Certainly that's so in Canada. It's very much so in Australia, in New Zealand, where I grew up. And here there was much more displacement and genocidal policies as existed in Canada, Tasmania, and other parts of the world as well. But we see the legacy of those things coming through in our practice. Forensic mental health services respond as health services, but around that and in that interface with criminal justice systems. And of course, the structural bias within criminal justice systems needs us, or the criminal justice systems rather need us in there, but we are prone to and at risk of being absorbed into those structural problems as well. And how do we guard against those things? The mental ill effects of poverty, substance misuse, and racism are clearly documented. So, and if you add poverty to that list, it's one of the things that's produced by that, we've started to refer to that and publish about that as a syndemic, as you can't understand the outcomes of race or of poverty or of mental illness or of substance misuse without understanding that they're all part of a broader interaction. And we've talked too little about that in mental health in general, and in forensic in particular. I've been involved in some debates, and it's another line of work that we're starting to pursue to link to interventions to reduce poverty as mental health outcomes and forensic mental health protective processes. Forensic mental health care is fundamentally, though, about understanding. Whatever it is we do, that's what we're in the process of. But if you're in the business of understanding a behavior, as we are, whether criminal behavior or violence or sexual behavior or whatever it is, behavior is the end product of multiple lines of causation of the person. And our ability to integrate those lines and explain those coherently to the people who need to hear that explanation is crucial. You cannot understand unless you can engage humanly with the person to make sense of those dynamics with them. It's been great work over the last 30 or 40 years to improve our rating scales, our structure, and our reliability in terms of our capacity to gather information or assess. But that's not sufficient in terms of understanding the narrative of a person. Some of the giants of forensic work, Ezra Griffiths and people, have pioneered the discussions of how do you integrate narrative and how do you get around the structural biases and assumptions that are involved in forensic practice without being able to address those things cross-culturally. So that's crucial, whether we're talking forensic assessment activity or forensic therapeutics. And I'll talk about both those dimensions to come. So I think that's all fairly clear, and I see a lot of nods, so I'll move on from that. The European Psychiatric Association, for instance, published a paper 2 years ago on poverty, on racism, that it contributes directly to poor health and mental health, that the effects of it are very inadequately investigated in research or controlled for or allowed for in our activities, and the multi-level impact of it at multiple levels are unexamined and unexplored. And in forensic mental health, we have been poor at systematically considering that, both in terms of our assessment capacities, although frankly, we've done more to try and address that area than in therapeutics, where we've done very little to describe what is needed. So for forensic psychiatrists in general, and maybe in particular, and many other psychiatrists, I think, we perform a vital role to help society be sure that the people it punishes aren't being punished for the effects of illness. That's what the NGRI, not criminally responsible jurisdiction, is all about. That you can't punish an illness, so there needs to be a way out of that. And we are the gatekeepers to some degree into that pathway. Or that people have tried the things that they can't defend themselves against, the unfitness to stand trial, incapacity to instruct, and so on. So we're important to the criminal justice system because by able to have those groups who come out, it justifies the moral authority of the law to punish everybody else who comes before it. So we're important in there, and also around issues of risk assessment in terms of the type and nature of sentences to be imposed. So we have a role in future violence. We have a role to help reduce the risk of violence and protect society. And as therapists, we have to reach into places of detention, remand centers, pre-trial and post-trial facilities, as well as run secure hospitals for the care, rehabilitation, and reintegration of those persons. So we're both an agent of and a participant in the criminal justice system, as well as a pathway out for people who find themselves in that situation. But whose agenda do we serve? How critically do we evaluate those questions in ourselves, in our own practice, and in the systems of care we construct and deliver? Forensic mental health services and secure services are secure and intimidating to people when they come to them. And certainly when I started out, it's very much thinking of, are we another oppressive state institution, or are we a place where my story might not detain me, but actually might free them by being able to share my story with these people who can make sense of what has happened to me. They will help me rebuild my life, rather than if I tell people what's going on inside my head, they'll lock me up forever and throw away the key. And that's the existential dilemma of the forensic patient coming into care. Clearly, I want us to be the former, not the latter, but it's an ongoing tension that's often played out in different ways. What particular efforts do we do to ensure that patients feel safe, respected, so that they are able to recover? Do we have one standard of care for all? That is to say, we've got a complex ethnic group so coming before us, and we'll treat everybody the same? Or do we try and understand each person and tailor treatment to the understanding of their origin? Do we consider ourselves culturally competent? And if so, what do we mean by that? And how do we examine and test openly whether that is true? Do we make erroneous assumptions about the thoughts and behaviors and the meaning of that of people across diverse cultures? So those are many of the challenges in this area that we face. As I mentioned, in the forensic assessment area, there's been more work and there's more guidance than there has in the area of therapeutics. And the Apple produced practice guidelines in forensic assessment that contains a very good section on cultural assessment and the things that you can do to allow for and bring in narrative about time, place, person, and meaning in terms of how that introduces into a formulation of the person's risk. 2016, that was a pretty visionary document in its own way. If you look for the same sort of guidance in forensic therapeutics, the cupboard is pretty bare. The Royal College in the UK produced guidelines for medium and minimum secure forensic facilities there, and contained under care that said that cultural responsiveness and the improvement of service quality is required. Very little guidance as to what that means or how you do it, or particularly when their auditors come, how that's measured. But nonetheless, they make that statement specifically. Otherwise, it's about national guidelines, and there's very little to guide us in terms of what we do with that. So with that background, it only took me 20 minutes. How does that fit with what I've done? So my geography is fairly large in this regard. I started off up here in Edinburgh, which is where I was born, in Scotland. And for those of you who will know in detail the declinations of Scottish place names, Edinburgh is the borough or the city of Eden. My family immigrated when I was very small, and I will say in terms of time, that was by boat when we came out. And so when I was very small, I was a baby when we left Scotland, arrived in Dunedin in the southern part of New Zealand, where my father took on an academic medical role there. Dunedin is the town of Eden. We went from Edinburgh to Eden town, a Scottish city at the far end of the world. Great geographical migration, small cultural migration. And that was where I grew up and trained. That's Dunedin, the University of Otago, which was my alma mater. And then for my clinical years, I moved up to Wellington, in the capital of New Zealand, which is where I finished my medical training and undertook my psychiatric training. But between the two, because it's the capital city, I was brought over by a Minister of Health from the Labour government and into his office as senior policy advisor, political appointment first in New Zealand in the Minister of Health's office. And soon after I moved into that role, the Auckland Hospital Board shut their forensic hospital with no provision of care for the people who were coming from it. It had been problematic over many years. No one had been sure what to do with it. There was no overarching model of forensic care in the country. The Department of Health didn't know what to do with forensic mental health, and there was a lot of surrounding problems with it. And so that was a failure of deinstitutionalization. Well, really, I prefer to call it a cavalier denial of service to a particular group of people of particular need. What they did was very interesting. They denied access from the prisons to hospital on the basis that people should be treated in the community. The offenders' community is the prison, therefore they should be treated there, with no provision or purchase model for that. And that forensic hospitalization didn't fit their model of community reintegration and deinstitutionalization. So those people were either discharged down to a very small group of very troubled men that were left. And they were moved to an early Maori mental health provider. So a indigenous model of healthcare, mental health care based on the communal marae based, the communal meeting area. They were really trying to establish themselves as a critical player in the mental health area and said, yeah, we'll take them on. So the most troubled people who the health system couldn't cope with were put on a fledgling Maori mental health provider who were overambitious. So you had this malign clutch between a senior health authority trying to get out of an area of work and a Maori mental health provider that were trying to establish themselves at risk of impugning all Maori mental health development as a whole. And of course, tragedy struck. 12 people died by suicide in the 2 major prisons that were meant to come in. That did not cause the government inquiry. Accusations of abuse of patients in that Maori provider also occurred. That didn't cause the inquiry. But a man who was from that hospital being turned away from the emergency department because it's sorry, you come from Oakley, we don't admit you, went home and killed 3 people. That occurred 3 months out from the next general election. And if you have a forensic tragedy, it's good that occurs 3 months out from a general election because you've got to have an inquiry. The government of the day has to have something to come in. And so that's what came in. And Judge Ken Mason and 2 psychiatrists, Henry Bennett and Eddie Hunter Ryan, took on that committee of inquiry and produced a brilliant blueprint. Came out in 1988. On the result of that, there was a recommendation that we would have forensic mental health services in all the major centres. We would have regional medium secure units and minimum secure settings in all of those places. But most important of all, that it would be the centre of all forensic services in that area. Court, prison, inpatient, community, liaison services, research and education would all be the responsibility of that. And as half the patients we were talking about were Maori, the services must be bicultural. So as I was, both as a clinical director in Wellington and later in Auckland, had to have bicultural skills. I had to have cross-cultural linguistic skills. I had to be able to at least speak sufficient Maori to be able to function across those. And the governorship of each of those services had to have Maori elders upon them to guide the implementation of that design. So when I finished my psychiatric training, forensic looked to be the most interesting area of psychiatry in New Zealand, the most troubled people, most seriously unwell, with the most interesting service model. That's what led me into forensic, and 30 years later, I'm very pleased I made that decision. The other thing that went alongside was 8 years later, or 10 years after, another inquiry by Ken Mason. And by the way, Ken Mason and the 2 psychiatrists concerned were all Maori. So that there's some wonderful stories associated with that, but that was crucial in terms of the development of our services. The New Zealand Mental Health Commission said the standard for all services in New Zealand should be a recovery-based framework, or as one of the female elders in the mental health area said, which one of my tribes did you steal those ideas from? The recovery principles of partnership, of the rights of citizenship, choice, self-determination, and hope that are imbued in the recovery model were very much in line with the Maori concept of health and well-being. So there was great resonance between those 2. And so we became, as a system, early adopters of the recovery model, because the way had been cleared for us in many ways because of the demands of cross-cultural work. And after 10 years and another 5 years in Wellington running services there, I then moved to an academic role in this place in Auckland, in the north of the country, where the original problems had been, but now had a visionary forensic service developing within that, and I became eventually clinical director of that service for 10 years, up to 2010. And there we developed, and this was after I left as clinical director, both concepts of care and venues of care that were architectural as well as clinical and philosophical integrations of those concepts. So when you're being received from prison or from court, you could come in through a venue like this with formal process of engagement and rituals of greeting called a porphyry would occur within those contexts as you came into the facility and then went off to the place where you were. So rather than coming in as we do at CAMH in orange jumpsuits with handcuffs or chains with 2 corrections officers beside you and a nurse or 2 in security to greet you, this is a rather different venue of engagement in the service. It sets a different tone to how things are done. So the centrality of relationship that Maori taught us and taught me, and Maori was said to be experts in time and connection of where you were from. Time, place, person, origins mattered deeply. Before people would listen to you, they had to understand those things about you, and that would clear the way for you to be able to be heard. The 4 cornerstones of Maori health that Sir Mason Dury, a psychiatrist, set out in 1984 were Te Taha Wairua, spiritual health, Te Taha Whānau, family health, Te Taha Tinana, physical health, Te Taha Hinengaro, mental health, was the way in which we structured our care plans and clinical histories. So you put a full Maudsley history or comprehensive assessment, but you tie treatment, therapeutics, and formulation to those cornerstones. And we did that for Maori, Pacific, and non-Maori, because all that stuff matters for all of us. These are Maori specific, but actually they're about all of people. Can you help us
understand what is the family structure there?
Family,
yeah.
whānau. So whānau is in a more encompassing term than family in a narrow, so it's not a nuclear concept of family.
Yeah.
It's a broader concept of relationship and role. So whānau would often come, if we had a family meeting, you would get 3 generations this way, and you may get 2 family systems that way. Or it may be people who you're related to by marriage or relationship or have known within family networks for many, many years. So whānau is a somewhat fluid in that regard, but it copes with cultural change, or if the parent was unable to look after the person, then the system of adoption, or whāngai, as it was called out within the family system, was a culturally normative event. And indeed, many kids would be whāngai to a grandparent or somebody else, not because there was a need to, but there was a communal sharing of child upbringing, and therefore of relationship and support and containment throughout life. So that was broad. And after you've gone through, once you're in a rehabilitation context with Maori, then you all become whānau. Once you've gone through the process of porphyry and of joining and of explaining yourself and coming together, then you are all whānau. So patients, staff become whānau. People are talked about not as patients or as residents or as clients, but whānau. So there was a universal human dignity and an equality that is inherent in those concepts. That's very important in putting a floor around, putting the context around which people develop and we interact. So it's a lovely system to engage in. And maybe you can see from that how concepts of recovery resonate with that. And except recovery, of course, is considerably, because it's US based. It's Laurie Curtis and people from Boston originally with the philosophical minds defining it, but that's a much more individualistic notion. It's much more of a collectivist understanding of identity in the Maori and Pacific system than in a European based one. So that was a different form, and your basic unit of clinical intervention wasn't the individual, it was the family. So if you didn't get family stuff right, you're in trouble. So we weren't working cross-culturally in that regard. Rather, we changed all of our practice into working in this way that became normal, became how we did it. And that, I think, was crucially important for everybody that was there. And we achieved some of the best outcomes in the world forensic literature. This paper from 2006 was about the first establishment of our community reintegration and follow-up program. No reoffending under our care, and only 10% among the people in the 3 years after who were discharged from our service. So I think that's still, I think, some of the best outcomes in the world literature. So it seemed to work. Didn't matter what your ethnicity was, matter what your age was, nor intriguingly did it matter what your prior antisociality was. And there may be reasons for that, which we can talk about later. So something about the breadth of engagement and whole of person approach, which Murray's required of us, is actually profoundly healthy for all people. And thence I came to Canada, that last loop of my journey in 2010. I've been 10 years in charge in Auckland, basically being in charge of a big clinical service. In my view, shouldn't last much more than about a decade. Otherwise, the place starts to take on your foibles rather than what the place needs. And CAMH came a call, and then there was something about what we'd done there that was of interest in Canada. So I came to try and do similar things there. Canada's a fascinating place, wonderful country, in so many ways, much lower incarceration rate than New Zealand, but just the same level of over-incarceration of Indigenous people and of people of colour. Much more structural poverty than I've been used to seeing. Didn't really know what panhandling was or homelessness to the degree until I came to Canada. And the structural poverty, what I mean by that, disability payments in Ontario today fund you to 60% of the poverty line. That's structural poverty. Especially when to get subsidized housing, you've got to be on a wait list for 7 to 10 years. To get onto an ACT team, you have to wait for 9 months to a year. So most seriously disturbed people, most trouble with housing, funded to 60% of the poverty line, taking 9 months to a year to getting the standard of community care they get. That's what we mean by structural barriers in simple form. It was much more ethnic diversity. In New Zealand, it was fundamentally Māori and Pacific and a few others. But in Toronto, hugely diverse, people from all over the world, migrancy, as well as you know, a very significant Black community, but of a very diverse origin: East African, West African, Afro-Caribbean, and Canadian groups all amongst that. So much more diversity, relatively less indigeneity in Toronto because the proportions are much lower. But of course, that's very different in other parts of the province and in other provinces of Canada. And despite recovery having been official policy from the Mental Health Commission of Canada for 5 years, very little recovery literacy at that stage in the hospital. One of the first things I did was to write an editorial on criminal behavior and mental health, trying to bring together recovery and forensic concepts because I could see that was a major block. And that's now my second most cited publication in the world literature, 160 odd citations since then. So there's obviously something we captured in that paper that's been very important to try and get around the resistance to considering these ideas within forensic. We then did a number of other things. We tried to integrate that into training and practice to bring that in, and wrote a second editorial 7 years later in CBMH. Tried to develop the concept and the practices of shared risk formulation, and noted the dearth of literature of culture and forensic therapeutics a couple of years ago, and ultimately with Gary Chamowitz from Hamilton, tried to contribute to the debate around what it is we're doing, what is the mission of what forensic psychiatry should be all about. So it's a part of propagating those ideas, trying to grapple with the structural barriers that people have and look at ways of doing that better. There are two major external drivers also to those internal ones of trying to do forensic practice better and trying to integrate recovery. And within Canada, one of those big domains has been the Indigenous responsivity issue. And the second issue has been the death of George Floyd. I know, very poignant in this city, and the requirements of that came. Indigenous responsivity issue is fascinating. The first major case in this area driving to try and get around the lack of Indigenous responsivity was a case called versus Gladue. And Gladue was an offender, a female Indigenous offender who had killed her abusive partner. And she had wanted to put issues around her developmental history, the wages of residential school problems and the effects on Indigenous populations of state-sanctioned abuse and denigration of Indigenous identity. Somehow that needed to be a part of her sentencing. The Supreme Court eventually agreed and brought down the requirement that that should be so. So Gladue courts, Gladue report writers have developed now as a specific skill set that is available for Indigenous offenders in the sentencing process, and also applies to Indigenous persons found not criminally responsible and unfit to stand trial also. So the first major change in the criminal justice system to overtly have to take on the wages of colonization. Because of the residential school system, is that something people are aware of? A lot of nods. So that was the state-sanctioned effect of taking the native out of the child within Canada. Yeah, starting around 1900. Finally, the last entries in about the 1960s and the final schools closing in Canada in the 1970s. And the whole process around that and the owning up to the history of that had been talked about and documented for decades, but never owned in the national psyche. And the Truth and Reconciliation Commission and explored that. And of course, the residential school system were just one of a whole system of state-sanctioned policies to try and isolate or depopulate and de-indigenate, if you were to commit a neologism, the Indigenous identity from Canada and the wages of that and the effect of that on Indigenous communities has been immense. So the TRC and the reconciliation principles, which is why that was in our land acknowledgement from earlier, set up a whole context within that we needed to respond to. And in 2018, a very interesting case for those of you who are forensically interested, R versus Hewitt. And Hewitt is a man with a very, very long criminal history, Indigenous man in federal corrections, and which is federal corrections in Canada is people sentenced for 2 years or more go under federal detention. All the remands, the pre-trial and the shorter than 2 years are in provincial detention. But so federal detention is under CSC, and they look after those people across Canada, including probation and parole. And they use structured actuarial assessments of everybody to work out security ratings, eligibility for programs, eligibility for release, and so on. And they had been under challenge by Mr. Hewitt for 15 years to norm the actuarial tools they used on Indigenous populations. As I mentioned earlier, Canada's been brilliant at producing risk assessment tools, the VRAG, the SORAG, the PCL, the HCR20, the SAPROL, all of those tools are Canadian, the START, the Static 99, all of those are Canadian schools, brilliant actuarial people, very, very able to do this, but those tools had never been normed on Indigenous offenders. And it wasn't as if CSC lacked a database of Indigenous offenders, but they had outcome data and reoffending data on thousands of eligible people that they got only tested on. And for 15 years, they refused to do it despite more and more senior courts telling them to do so. Finally got to the Supreme Court and who found against CSC and found that their use of actuarial tools to assess Indigenous offenders was arbitrary because it had not been tested as to whether those tools had predictive utility on that population or not. That story is interesting because it raises the lid on on how we employ risk assessment tools in forensic in general. It is also a window into organizational resistance to change. So that led to a very interesting analysis as to, and a look at how we use risk assessment tools in general. The murder of George Floyd had huge resonance in Canada because there was already extensive controversy about police shootings, about people with mental illness and crisis, a number of whom have been Black in Toronto, and the RCMP, the Royal Canadian Mounted Police's shooting of young Indigenous men primarily in a number of provinces. So Black Lives Matter became Black and Indigenous Lives Matter, and it became a huge issue, not with, sadly, the rioting and the suffering that occurred here, but with the same moral weight of demand on us to get our act together in relation to EDI themes. Which led us to the issues of how we have tackled it in CAMH, and that'll be the final part of what I'll talk about. So the service that I led and am now a part of, we have 190 inpatient beds, both for assessment, but primarily those are inpatient, medium and minimum secure recovery units, and 250 forensic outpatients. By forensic, we mean not criminally responsible or unfit to stand trial. So we don't have the dangerous civilly committed ones coming in as you do here. It's much more defined by that narrow criminal justice pathway. We also have large remand services for pre-trial people in custody. We have court liaison and sexual behavior and other consultation services as well. Marked overrepresentation from BIPOC communities, as mentioned. We knew a little bit about the issues of both indigeneity and ethnic diversity. We did know that seclusion and restraint in general didn't show an overuse amongst people of color within our program, particularly not entirely true if you were young and Black, and that's an issue I'll show you in a moment. But Black patients expressed 20% lower satisfaction with the care they received, and we didn't know what that was about. But it did seem like your rate of progression through the forensic journey, once you were in, was no different by ethnicity. It was very different to coming in. But once you were in, it seemed to be broadly similar, which is reassuring, but of itself not enough.
When you say rate of progression, is that assessment and rehabilitation, recovery and discharge into the community, or are they going traveling?
Correct. So it's through that journey and through to what we call absolute discharge. So your ultimate cessation of forensic patient status, which is after usually at least 2 years successful community living. So after whatever your inpatient trajectory, plus that on the end, the rate of progression from initial entry to absolute discharge did not differ by ethnicity.
And who does this funding? This is socialized medicine, this practice, it's government funded, right? All of the healthcare there.
Correct.
Do they carve out a piece of it for the forensic aspects of an individual's care, or how does that work?
So it's all, yes, it's all government funded. So through various buckets of government funding, obviously, for the assessment services that comes through the justice arm, but all the clinical provision, including the secure care and recovery, all of that is health funding.
Because it'll be so drastically different in our system.
Sorry?
Coming through this private sector insurance operation in our system here in America.
Right.
That is so different to bring all that funding under one roof and to have that programming, because there'll be two different levels of setting as to when this patient with recidivism or something would be transferred to that kind of setting.
Right. There's extensive NGO involvement in community provision and housing and community supports, but most of that is, it's all government funded by various contracting systems. Physician remuneration is a mixture of stipend and OHIP, which is the Ontario Health Insurance Payment. But that's a state funded insurance process that we bill for that. So it is all ultimately the public purse through various avenues. So if we look at the demographics of who we're looking, the blue pieces is the Black population. You can see the proportion of women, and of younger people is much higher for young Black men than for all patients. So there may be something obscuring course and outcome that sits in the different age groups within that. We from 2017, we started to do this formal structural work around establishing what the mission and vision of the forensic division and the forensic services should be. So we're an academic division as well as a clinical division. And advanced and secure recovery became our mission statement, and we developed and continue to develop a comprehensive model of care to describe all of what we do across that pathway, what our standards of assessment are, the time of assessment, the nature of care and provision that people should receive, such as if you're an inpatient, how many hours a week of structured programming you should receive and you're entitled to, developing particular rehabilitation arms for psychosis, for neurodevelopmental problems for women, and so on, and measuring course and outcome with measurement underpinning all of that. We just started to publish that. We have a paper in press describing that with a logic model attached to it coming out shortly. Cultural responsiveness, as we called it in 2017, EDI as it's become known now, was one of the 5 pillars upon which that model of care was based. And our response to that has been since 2020, has become much more comprehensive and multi-leveled. And I'll talk about that now as to how we try to tackle that as a reasonably large forensic provider. So the EDI vision is stated there. We talk about a culturally safe milieu for staff and patients. Why safe? We often think about building up staff competency and think of ourselves as culturally competent practitioners. That's cool. Staff competence, however, is not the end. Staff competence is a step along the way to cultural safety, because the only thing that matters eventually is what patients experience, and that's whether they feel culturally safe, listened to, and respected by their clinicians, regardless of the education we receive or the competencies that we think we hold. Yeah.
It brings me to a question that I had earlier. Actually, you had said that there was no difference once they kind of got in the program to when they completed the program, patients. But that was more for the perspective of their treatment from providers, I imagine. How did patients, was there a difference in how patients perceived their treatment at all according to groups? Yeah,
that was a narrow temporal description of how long it's taken through. We don't know enough about the different levels of experience of that. And there's something going on when we saw that 20% lower satisfaction with service that Black patients experienced. So there's something going on there, but we could hazard guesses as to what that was. It didn't seem to be impeding the rate of progress through, but one of the things we do know, and we published, Samita Chatterjee and I published the paper of outcomes of what happens after you get your absolute discharge. After we had both had quite a number of people who had got absolute discharges, who had been doing well for long periods of time, falling over very rapidly once they got out of forensic care. And we weren't sure what that was about. We seemed to be good risk assessors and managers while under our care and helping people make good progress. But the ability to generalize that learning beyond our care, we seem to be bad at predicting who could take that forward in general mental health settings and with new practitioners and who couldn't. And we saw the same in New Zealand, that there was no difference in terms of your rate of recovery and progress for Maori, Pacific, and Pākehā for white New Zealanders. No difference across between those groups, but the people who fell over after forensic status were disproportionately Maori and Pacific. Now here we didn't have enough numbers to do major divisions by ethnicity, but there's probably something in your ability to transfer and carry over with you trust and expectation that you'll be well cared for that may be different if you're running at lower levels of satisfaction lower levels of engagement or higher levels of resentment about the nature of the compulsory care you're getting. And there's probably a lot of stuff around procedural fairness in that, about legitimacy, which are concepts which I think are very important, but we haven't measured well enough in a structural way to explain that. My hunch would be that's where the action is, but we're not sure about that at the moment. So
I'm sorry, how
Yeah.
did you measure that, you said dissatisfaction, right? And then you also said they fell over, did they come back into the system again
yeah, so reoffending.
Reoffending.
And
to the same degree?
no, almost everybody reoffended at much more minor degrees than their index offending. In our outcome study that we did in Toronto, similarly in New Zealand. So nobody reoffended at the same level of seriousness as the index charges. But certainly it's that ability to carry with you the gains you achieve under forensic care. And it may be something around both the philosophy of care and the assertiveness in the context of quite deep levels of caring for people, which I think is what people experience certainly in New Zealand, and to some degree, I think in Canada, which is you have to negotiate that somewhat differently in larger services that are where you have to take much more positive steps yourself to ensure you're getting good follow-up, where the assertiveness may not hold you in the same way, in a kind of Winnicottian sense of holding, and that I think fails for some people. And if you have a cultural wraparound for that, you feel much more held as a person within a culturally integrated service than in one where that integration doesn't occur.
And or you're entering into, as you do that step through, right, you're entering back into a system riddled with structural and implicit racism. So you're moving from a safe world into an unsafe world. And if you're a person of color, that lack of safety is sort of multiplied, right?
Correct. Yeah.
So you're increasing the stress load, basically.
Yes.
And
Yeah.
actually, somebody in the online just echoed those thoughts. Patricia Carlson said, could that be systemic racism rather than the fault of the individual?
Yeah.
Yeah. I think there are. I mean, fault is an interesting thing in forensic, but that's another aside. But it'll be lovely to discuss. There's none of cultural understanding or formulation is to take away responsibility for the person for living their life well. And as I frame the NGRI or NCR recovery journey, and well, other people wiser than me, when ADSET in the UK refers to recovery as a personal journey within general mental health settings and in forensic settings, it's a personal journey and a moral journey, because your duty is you by being made NGRI or NCR, as we call it in Canada, you're not being punished for what you did, but your accountability is to live your life well so that that problem does not emerge again. And that's a moral responsibility. And how we talk about that with patients, how we help them integrate that into how they think about it, how our own comfort in being able to have those conversations around the seriousness of risk and the issues that if you are cavalier about your treatment in the future, you will put others at risk, potentially at fatal risk, because of your lack of sense around how you manage your health and illness. So it adds an extra duty on people. That is what the responsibility holds. So you may not be responsible for what you did when you were floridly unwell, but you are responsible for maintaining your wellness so that others are not at risk going forward. And that's that's the extra level of complexity around that. It's a lovely review of forensic recovery that came out, and I'm blanking on the name of the principal author. Begins with S, which looks at these using the CHIME S, CHIME concepts of recovery, adding an S for secure, which is a meta-synthesis of all the forensic recovery journeys and the qualitative studies in that area, where patients are talking about the need for S and the nature of that moral component of their recovery that's different from the recovery components for people without a forensic history. So how we integrate that piece in So the sense of personal identity is really crucial in forensic, and we don't necessarily do that well or purposefully in terms of how we do things. So when we looked at, we kind of went headlong into this and did what we thought was right. And then when we tried to write it up, we thought, well, how do we write up this mess of things that we've done? We found, of course, there was somebody who had already written about it. And in this, Selman and colleagues in 2015 published a review of, they looked for systems of EDI responsiveness in systems of mental health care, not in an individual program or an individual treatment, but in a system of care. And they found 7 across the world, I think a couple from the US, from Australia, and from across Europe, where there was a system of care looking at how to address these concepts. And they came up with 7 key domains that needed to be addressed. Organizational commitments. It's the same with recovery, actually. You need an organizational commitment to recovery to make it work. You need empirical evidence to look at. So you need to have that driver of need to support what you're doing. A competent and diverse workforce, ensuring access to all service users, ensuring responsiveness in care provision, fostering patient and community participation, and actively promoting responsiveness. And Healy et al. A couple of years after that looked at the mental health literature to look for examples of where EDI principles or specific cultural responsiveness have been built into aspects of clinical therapeutics. They found 31 studies only in the world mental health literature, none in forensic. So in terms of specific literature to guide us, we're on our own in this area, although the imperatives are clear. We published last year in the Journal of the American Academy our approach to this, and we took those 7 down to 6 headings: organizational commitment, staff and workforce ones we conflated, as you see, service access and delivery, promoting responsiveness, community outreach, and data collection. And so we'll have a look at those things in terms of how we did them. Strategy, organizational commitment, promoting responsiveness, community engagement. So you got to have people from the relevant communities coming in and looking at you. This is not a thing you can do on your own. Data collection, service access, and so on. So the strategies, so we had over 40 projects involved overall, linked to multiple people. Action plans using CUPA designs, quality improvement designs across all of it. So much pre-post, much focus group, much recorded outcomes and feedback on individual projects. Working groups, discussions and completion of tasks, and an overall EDI strategy group that has community representation and patient advocacy organizations on it, as well as the forensic group as on itself. So co-creation with service leaders and peers was a major component of the first piece, the QI approach I've mentioned. Generating a momentum across the group was really important, and communication. Last year, we had 5 priorities. So the individualized piece was led by the introduction of the cultural formulation interview. I think the document came out in what DSM and DSM-4, I think, was in the first in that, and it's in DSM-13. So there's been 1 adaptation of it for correctional settings by the Yale group, but no documented use in forensic settings. So we've now mandated it. And there've been a lot of issues as to how we roll that out, but it's now going very well. A lot of why you're asking these questions. In other words, is this a safe space for me to talk about my identity, my spirituality, and my cultural practices? Many steps to overcome that, which is a whole presentation in its own right, but we've got publications coming on that. Documentation and education. Oops, I'm running low on power. My cord is in my bag. Does that?
Yeah, that should work.
Thank you. No, that one's not.
No. There are PowerPoint, yeah.
Documentation and education refers to the education of all of us, but also the look at our own clinical documentation and bias.
Can you plug it this way, on this side?
Switch.
That
That's
should
just-
can't reach it.
Okay.
Oh, here's anyone that doesn't close it.
We, with, so while that goes on, I'll carry on talking. With,
Well, You know, you could quickly shift to this side, this is closer.
okay,
I know it's clunky,
my apologies, our online audience.
or, yeah, yeah. Yeah, you can. Yeah. We do have the slides on the screen as well, so.
So just bring the microphone over.
Yes.
We've adopted culturally specific programming such as culturally informed CBT. Make sure all of our materials work cross-culturally, and data, measure everything. So the cultural formulation interview I've mentioned, and that's been pretty foundational in terms of expanding the nature of identity and how we integrate that into what we do. And we do that with patients and with families. The question is, when do you do it? At point of first reception? Oh, almost certainly not, but within the first 6 months, and how that's done is important. With a data working group, documentation working groups, considering looking at how we use language and the implicit and explicit bias in that. A lot of work with feedback from patients. We've got anti-Black racism groups for staff and for patients. Why for staff? Because there's significant issues of horizontal violence and racism within teams that needs to be have venues to overtly talk about. Not easy conversations to have, but have been vital. Culturally adapted CBT I've mentioned. We're developing a mental health court diversion analysis. We've got some state-funded diversion services, but their utility and ability, how they work in terms of a point of effective diversion, we don't know. And female forensic pathway is vital for the overrepresentation that you saw. Data. Data is remarkably difficult to get right, but working out what measures we should be using and how to employ that in a way that's effective is very important. Recognition that data will likely show, as we bring to the surface, processes that may show an increase in dissatisfaction, because if we change people's expectations that they should feel culturally safe, they may be much more attuned, rather than shutting off that side of themselves to the process of negotiating and new relationships and new understandings about that may be tricky. So we're ready to have a less satisfied patient population if we're moving in a way towards better understanding. The importance of continuing to roll data collection and see how we're doing, so how to use dashboards and feedback data for the teams, but making sure that this is sustainable, that these aren't one-off activities that will kind of be nice for us to do programs for a while, but then it ceases to be to work. So sustainability is very important. And we've developed these different tools to gather information across our electronic medical record. And there's been a huge amount of investment in the CAMH-EMR to make it responsive to forensic issues, so that we can track things like programming, individual group activities, and each of the rehabilitative pillars and mental health awareness and education and offence-specific behaviour and substance misuse work and education and personal growth and identity. So the major pillars that we have for our rehabilitative activities, we can measure access, involvement, and outcomes in each of those pillars for people across the service now. We couldn't do that 4 years ago. And so we have developed then the ability to look at negative ratings, things like restraint use, ULOA, that's absconding behaviour from our hospital, ALC, that is alternate levels of care. Those are a nice way of saying we can't house this person, they're stuck in hospital and they should be somewhere else. The DASA, which is the dynamic assessment of situational aggression, is that a tool that people are familiar with? You're using Brexit. So yeah, that's two. Yeah, they're very similar tools. We use the DASA. It's worked well for us, but it allows us to profile the population in terms of who people are looked at and risk. And because we do it on everybody every day, and it's in our EMR, we've got now tens of thousands of measures. So we're hopefully going to be able to look at that and look as to whether there is structural difference in how how staff are reading behavior of young Black men, for instance, versus other people. So record level data by race and record level data in relation to clinical dashboards, progress, and by being able to look at passes and privileges and progress, the rate at which people achieve and are successful in the program we can look at. Got some ability to do that by gender as well, and we are, but by citizenship or language, or by the other drivers of inequality, income level or homelessness, we haven't been able to break that down yet because our data quality is not good enough in those areas. So it's just to kind of look into the way in which we're trying to bring data we've got to with reporting and analytics to come across to be able to measure whether we're impacting or have problems across the EDI dimension and whether we're addressing those things actively. Why is that not progressing? So we've looked at, so the CFI we track both in terms, and we've done studies of both the content of what's being reported, which is being written up at the moment. Hopefully we'll submit that soon. And when and how they're being completed. Cultural adapted CBT going on for the Black patients is being evaluated. We have both team anti-Black racism work, so that's among staff groups as well as patient-based, which is peer-led, and continuum of support, debriefing meetings to look at how the overall structure of this is going and overall satisfaction runs. What we need to do is to survey, and we're not looking at patient satisfaction routinely in a way that allows us to track how we're doing with that 20% disparity that I mentioned earlier. So aware of time, I'll maybe flip across this and we can talk much more about culturally associated CBT, but it's become both about CBT and about the Black patients being able to talk about issues for them more generally. So it's become a blend of consciousness raising as well as specific tools to help them with the impacts of affect dysregulation and so on. For staff, these have been very important, led by nursing and social work, with careful supervision by unit staff and access to both networks across the hospital for Indigenous and Black providers to have communities that are safe to deal with and to discuss those things. It all started after George Floyd's murder and the impact that had on staff and what were we doing about it, and it's flowed from there. So it's been a very positive thing that's come from it in terms of grappling with a lot of stuff that was not addressed well within our programs. And those conversations and support continue at patient level. We have peer-led meetings in all of our units, with Black peer groups that also build on the culturally adapted CBT to assist Black patients. With minutes, there's a strong sense that it's their meeting and that enhances their ability to have agency in this work. So when issues like, expect the death of someone who had recently been a patient within the unit in the shop that brought, you had this network of building trust and relatedness amongst the groups that was strong and able to assist patients in dealing with that. I must say that was one of the other things that I noticed when I came to Canada from New Zealand. In New Zealand, the patients strongly supported each other. That sense of whānau that you asked me about earlier, of family, that existed amongst them. And the guys informally developed the sense together that they would do things. They often wanted to be discharged to group homes together to continue that support. And they became whānau to look out for each other. That was absent, totally absent in Canada. That sense of being in it together, it's a sense of group identity and community. I didn't see, but this was interesting that you start to see that emerging organically when you create the venues for this sort of level of discussion to occur. So what are we trying to do? Get greater equity in our service provision to enhance shared decision making, and that's partly a recovery goal and it's partly a cultural responsiveness goal. Personalized care comes from better cultural understanding and transparency and accountability with community groups, with others to hold us to account in terms of what we're doing. It's a work in progress. The risks in all of this, that it's too little, that it feels tokenistic. How many of us have been through things that feel tokenistic in their form, that it lacks focus, that we're not measuring it, that we come in and we do something for a while and then something else becomes flavor of the month. That there is some shared attention to it, that it doesn't become business as usual. In New Zealand, it was business as usual. Making this business as usual was quite a big leap for us. But our biggest mistakes aren't in the mistakes we make as we try and do this, and sure, we've made many along the ways, but our biggest mistakes are the things that we don't do. That we don't do it well enough, we don't do it early enough, we don't do it with enough energy that it deserves. And partly there's a lack of evidence to guide us into how to do this, and partly we're nervous about getting into difficult, tricky conversations that trouble our community and have a lot of politics and assumption associated with them. But my experience throughout my professional life has been that it enriches clinical practice hugely if we do it. We're better clinicians for doing this well. We're better therapists, we're better assessors. They're better places to be able to help people. So I will stop at that point and love to take questions, and thank you for the questions already as we go.
Thank you. I'm sorry, I didn't want to take all of your time, but one thing, we started the conversation saying a lot of these patients had some kind of a psychotic disorder diagnosis or a label. Mm-hmm. Was that true for majority of your patients? And my second and third question is, what are we doing about prevention, right? Instead of having to build these hospitals and prisons, what are we doing at the prevention level? And my third question is, one side is the offender, but then the other side is the law agency, right? Law enforcement agency. What are we doing regarding how they approach these patients in terms of their training and their responsibility?
Right, so 3 questions together. I'll forget your first question. So the diagnostic profile of the patient, yeah, just like any other standing forensic population, 85% with a primary psychotic diagnosis, 10% with a primary mood disorder, and the final with a variety of largely neurodevelopmental or degenerative disorders. So with, as you'd expect, 60, 70, 80% comorbidity with serious drug misuse, the usual profile. We have about 50 to 60% with a primary violent index offense, and a number of others with another violent offense, or more minor offending that is a more persistent variety, about 15 to 20% with a primary sexual offense. So yeah, largely it is a psychosis and violence program. So that's who we treat, and average age of entry into the services in the mid-30s. And usually they've had 15 or 20 years of illness prior to coming into us. Developmental trajectories, which is an area that I'm very interested in because for a variety of reasons, but about a third to 40% are early starters, so they have conduct disorders or antisociality prior to the onset of psychosis. The remainder are late starters, so that the criminal justice involvement comes at or after first symptoms. And amongst them are the late starters, who are usually 15 or 20 years after symptom onset, who often commit a single and severe violence action. So it's often an intrafamilial homicide or something like that comes in your 30s after years of treatment-resistant symptoms. So, sorry?
Prevention strategy.
Prevention strategies. I mean, we're a tertiary prevention service in forensic. We're the people who come at the end of the line. I mean, even our prison services are tertiary prevention in that regard, although we're trying to at all times divert people away. Forensic prevention also comes in terms of helping general mental health look after people who present problem with psychotic illness, who are violent, and the way we can help consult and improve those things. Our advocacy around the competence of mental health services generally, and the provision of ACT level care for people in the community is crucially important. But our advocacy more broadly, and this in the last couple of years, is an area I've got drawn into much more after a series of, or a rapid increase or cluster, we're not quite sure which of all of those things are because the data is not great, of serious violence and homicides on the Toronto TTC, the public transport system. There have been police shootings of people on transit who were acutely behaviorally disturbed, and there were 3 homicides over 18 months in and around the settings. And what was fascinating in the public debate that came after that is, although we had a populist, and we have a populist conservative premier, we did not have an outbreak of populist response. There was a little bit of, we need to lock these people up, but most people said this is complex because they've seen the homeless people on the streets of Toronto. They knew housing was awful. They knew serious drugs were a major issue. They knew mental health services were inadequate, and they got that this is a complex problem. And one of the things I got interested in then and started talking about is, what do we do about that? And we talk structural poverty, we talk about those things, but we don't talk solutions. One of the clear solutions is guaranteed or universal basic income, which is tested and tried as an economic model in multiple jurisdictions. The left tends to like it. Milton Friedman loved it. So parts of the right like it, parts of the left like it. But it's an easy target, particularly if you call it universal basic income, because universalism has all sorts of problems. But it's general crime preventive, and it's mental health promotive contribution for people who are marginalized and poor is very significant. And if we wanted to argue for a general health promotion that would result in improved mental health outcomes and likely have impact on criminal justice pathways, then GBI is a great thing to advocate. So I'm starting to do that. I've got a summer student reviewing the literature on what's called in the literature unconditional cash transfers as an intervention. It's a lovely study out of Denver that's just started to be reported in the last couple of months, showing significant reductions for people with serious mental illness who are homeless, and homelessness, and criminal justice involvement in incarceration and hospitalization. and they're primarily publishing at the moment the economic benefits of doing so, but I'm sure there will be coming the more detailed analysis of how it impacts mental ill health outcomes and criminal justice outcomes. So if we wanted to seriously look at prevention, then we should be advocating for things like that. This is bigger than what we can do mental health wise. You had one other question.
I was talking about the law enforcement end of things, and I think that's part of the responsibility and how the community handles these situations and these patients and people with homelessness and all of that.
Yeah.
So training and more responsibility, culturally responsive training is what they probably need. Instead of, going and shooting at people or wanting to incarcerate them. What exactly happened to George Floyd here?
Absolutely, and there's been a huge effort to develop different models to the police intervention for emotionally disturbed persons, as it's called, north of the border. And there's been some successful models with that, as there have been here, the joint police and the mental health responsiveness teams and mobile teams and so on. So there's good evidence that those things work better. I must say, from as I grew up in my training in New Zealand to the models that exist in the UK and in New Zealand in response to psychiatric crises, what I note here is the retreat to the hospital by health services. So community-based people in distress, which was mental health just withdrew away from, and the burden of response of that fell onto the police. We hid in our emergency rooms and based our response teams away from the community and put that on family and the police to bring people to it. So I think we failed the mental health overall in many of our models of practice by withdrawing from community responsive acute services. Whereas if you look at the UK model of acute responsiveness, you have a designated social worker under the Mental Health Act. And so when you ring up to an acute service, you have people dedicated to go out who have authority under the mental health legislation to assess the needs, to bring people to hospital, to initiate civil commitment processes, and including calling in the police if that's needed, but not making the police the first line responders all the time.
The US is making that shift gradually. And I think I mentioned earlier in Minnesota, we have mobile crisis unit teams, which are manned by mental health social workers and peers.
So mandating that, I think, in mental health legislation, as the UK, or the English and Welsh model is, and New Zealand mental health law does that. We have things called duly authorized officers in New Zealand who do that. So if you've got your person in crisis, you don't ring the cops in New Zealand, you ring each area health authority has to have an acute assessment service that includes that mobility with the ability to bring in police. So I think, I mean, those models are better. And I think many of the times where police get into trouble is when we've abandoned them to that process alone. So I think that's very important.
And Sandy, in the US, you probably are aware, we launched a centralized 988 number.
Yeah.
That came out of the, it's a hotline.
Yeah.
It came out of the National Suicide Hotline, but it's now supposed to field all calls in crisis mental health. And within the first year it was launched, it's fielded over 4 million calls.
Yeah.
I have one more question
Yes.
in the audience. Richelle's been waiting for a very long time. Richelle, I'm gonna try to unmute you if you want to read it out yourself.
Can you hear me now?
Yes.
Okay. So I was curious about what the family intervention component looked like. You referred to family-focused care. I really want the residents to really appreciate, and fellows, the importance of the family. So you're my voice.
In New Zealand or in Canada?
Either one, yes. And what we should do here.
You got to go with your local cultural mores, because who defines family and who defines a right to be at the table is different by cultural group. In New Zealand, with Maori, the unit of clinical intervention is the whānau, not the individual. So much decision-making can be made with the family. And there's an obligation in New Zealand mental health legislation to consult family unless there are overt reasons as to why not. Whereas in Ontario mental health legislation, there's no such provision for that. And we're much more involved in personal decisions. And of course, the more we individualize things, the more we put things on individual relationships or an individual person, the more dangerous it becomes. People are healthiest when we're connected, not when we're isolated in all sorts of ways of life. And it's no different in clinical decision making or around, whether it's consent to treatment or other issues. How did that work in practice? Well, you saw the one of the newer venues for engagement with people. So that would not be, if someone was coming in pre-trial for assessment or from prison, that would not have family at that point until the security issues have been dealt with. But we had within the secure setting areas where family could come in and where those interactions could be facilitated. And we had specific members within the clinical team whose duty was to attend to Te Taho whānau, family health. So that was a core component of what occurred. And so linkage with family was a core expectation of every person's care. And people wanted to be engaged. Now, there are times, of course, one can't get romantic about families. Families can be places of abuse, and there can be unspoken and spoken about abuse that it can be difficult to talk about and those things. So that needs to be thoughtfully done. But generally within that broad Maori concept of whānau, if the narrow family had been abusive or were still gang involved or substance misusing, you just went out in the family system until you struck health, and then those people would come in, and the family would guide you as to who the people were and the person would want. And we had those elders and Maori liaison workers who would reach out. Ditto for Pacific, people, Tangata Pacifica, people of the Pacific who were in with Samoan and Tongan elders working with us that would help us with that process as well. So you did what you had to do to find the people who should be at the table, but people making decisions alone or with their lawyer alone is fundamentally unhealthy within a Maori context. Of course, if that's what the person wants to do, ultimately one must respect that, but that wasn't the norm, and people knew that that wasn't the usual or the healthy way of doing things. And that became practice with European people too. Most of us have family care people that matter in our lives. We like to bring the family along with us, and if they can come as allies, of course, that's crucially important. The trickiest work in forensic with this, of course, comes where you have an intrafamilial homicide or serious intrafamilial violence. And that stuff blows families to bits, and for obvious reasons. And some people will identify with and stay in relationship with the other people. Some people can't face the person again for having killed a loved one and someone who indeed usually they loved also. And so the emotional enormity of that is too great for some people. There may be persistent anger and hostility with that, and bringing those families back together again can be a very long and slow process, at times intensely moving when it's achieved, and at times you just have to go with what the elders say. We had one, I won't give you the details of the case, but it was a killing of a child within a family, and the mother of that child couldn't face the perpetrator, although she also recognized that he had been seriously unwell and was basically a good kid with a seriously nasty illness. And other family members came and supported him, and he did very well in his rehabilitation, but she couldn't face them. And then one of their parents died. And in the Maori setting, you have a funeral that's called a tangihanga, and it could go on for days. You almost always does go on for days, 3 to 5 days. And of course, you can't be together at a tangihana for 3 days and not laugh and cry and weep and laugh and enjoy and feast and relate. And so you get these waves of grief and reconnection. You get groups of people coming where the grief is shared again, and then the new links are forged. At this particular tangi, the two siblings came together in the same room for the first time. And our staff were escorting our patient there, and the elder said it's okay, and it was. And the two of them, around the death of their parent, reconciled. And I don't think we could have done that within a Western frame at all. But the elders knew what they were doing, and they read. So it's a beautiful example of how you can resolve those things at times. But there are many where you can't, and you just have to go with what you have. So the enormity of the load that some forensic patients carry, and how you make sense of that is guided when you've got this ability to work broadly within family systems and bring them together. I don't know if that's helped you.
Yeah, thank you very much. Appreciate it.
And I think we're a little over time now, so I just really have time to say thank you so much. Clearly very engaging. I have several questions. I'm sure others do. We can continue over the lunch hour. But thank you again for visiting and for this wonderful discourse.
Well, absolute pleasure. Thank you.
Doug, where's